Hello and welcome. My name is Daniel Helbling. I'm a medical oncologist. We are here at the ASCO Update 2013 in Zurich. Next to me stands Dr. Andreas Müller. He is a breast and gynecology medical oncology specialist, and he reviewed for us the data which were presented at ASCO 2013. Andreas, which were practice-changing studies presented at ASCO this year? What would you consider really practice-changing?
To me, in the field of breast cancer, the most important trial was the ATOM trial, which has been presented at the plenary session. The topic of the ATOM trial are 10 years of tamoxifen in the adjuvant treatment of breast cancer better than 5 years. So actually, ATOM trial was a companion trial to the ATLAS trial, who has been presented last year at the San Antonio meeting. It had the same design, but with only patients from UK.
Okay, and what was the major finding? Was it better to prolong the treatment for another 5 years with tamoxifen?
Yes, it was better in terms of a reduced relapse rate and also a reduced breast cancer mortality. There was no significant difference in terms of overall survival, which could not have been expected because there is about half of the deaths which were not in relation to breast cancer events. This better outcome in terms of relapse and breast cancer deaths came with a price in terms of somewhat more endometrial cancer deaths, but in a very low rate.
Okay, so 10 years is better than 5 years regarding disease-free survival, but the difference was not too big. And do we know something about the subgroups? Are there any subgroups benefiting more?
There have not been subgroups demonstrated. The hazard ratio for reduction of relapse was 0.85. The difference emerged after let's say 10 years. So this means 5 years after the extended tamoxifen. And in absolute numbers, these are about 3% difference in breast cancer deaths.
Okay, so there's surely a difference, a benefit. Mm. So now, to whom would you now recommend another 5 years of tamoxifen?
I would recommend this extended therapy to patients with a higher risk, especially in women with node-positive breast cancer, and for those who tolerated the first 5 years acceptably. If the patients ask me, "Doctor, is there a possibility to do more?" then I can say, yes, there is a possibility. If a patient says, "I'm done with the therapy, can I stop now?" then I say for sure it is possible to stop. The difference in what you can gain is rather small.
Okay, so it is for a selected group. It's probably, these data are probably interpreted in a very different way around the globe, but in Switzerland now there will be a change probably in practice towards more or longer tamoxifen treatment for some patients, I think.
This is a difficult question because in the ATLAS trial and in the ATOM trial all patients had to have only tamoxifen for the first 5 years. And in Switzerland, almost nobody has 5 years of tamoxifen in his endocrine treatment, unless they are premenopausal or they don't tolerate aromatase inhibitors at all.
Okay, so and if they had an aromatase inhibitor, we don't have any data to give them another 5 years of tamoxifen.
Neither ATLAS nor ATOM do justify extended therapy after 5 years of an aromatase inhibitor.
And if you had a switch therapy?
Even in this situation, these two trials don't prove the use of prolonged endocrine therapy.
Okay, even if you had a switch with aromatase inhibitor and tamoxifen for the first 5 years, there is no clear message
data until now, but there are trials underway who are looking at this.
Okay, good. Thank you. Was there anything else regarding, I think there was something about cervical cancer, correct?
This was the most exciting abstract to me. Also at the plenary session there's been a presentation of GOG 240, which was a trial for patients with relapsed cervical cancer, which have a very dismal prognosis. They usually are treated first line by radiochemotherapy with cisplatinum as radiosensitizing agent. And after relapse they have a median overall survival from about a year. And the GOG trial 240 look now if you could improve the survival of these patients by adding an anti-angiogenic agent to chemotherapy, in this case bevacizumab.
Okay, and it was better regarding?
It was clearly better. There was an improvement for progression-free survival and for overall survival in a very meaningful way. It's about 3.5 months longer overall survival in highly statistically significant difference.
Okay, and what was the overall survival? How long was it? Was it a year or something then?
In the control group it was about 13 months, so this means the control group did not underperform. It was very reliable data.
Okay, good. So there is a new kind of standard for those patients who have recurrent or metastatic cervical cancer, correct? Is this the group which was treated?
It was relapsing cancer after radiochemotherapy or primary metastatic.
Okay, I see.
But this benefit came with some price. Patients in the bevacizumab group had 7% perforation or fistula, which means that I would be careful in using this agent in this population, cervical cancer with infiltration of rectum or with the bladder or with bowel obstruction. But in the other patients, I would select this as a standard treatment.
Okay, thank you very much. This was a clear message for whom you would give it and for whom not. This is a Swiss perspective, but I think, or I hope it's of value for the viewer as well. Andreas, thank you very much for joining us
You're
here.
welcome.
Bye-bye.